This is Dr. Evan Osar. Do you have your clients doing exercises like clamshells for knee pain? Have they been recommended by their physical therapist or chiropractor? Do they actually ever help your clients? Hey there, this is Dr. Evan Osar with Integrative Movement Insider. And that's a legit question. It's sort of a joke as well. Do they actually help your clients? Do clamshells actually help your clients? And do you know why you're using clamshells? Do they actually strengthen your clients' hips? And then if so, how do they strengthen your clients' hips? Because most of our clients don't have problems lying on their side. They have problems standing up. They have problems balancing. They have problems walking. So in this Facebook Live, I'm going to share with you the 3 don't do exercises. I just showed you one of them. Now, the caveat is, if your client has been recommended to do these exercises by their physical therapist or chiropractor or medical professional, then yeah, you need to have a conversation with them. You can't just say, hey, stop doing those exercises because Dr. Osar told you to. No, you have to take your client's history. You have to do your own assessments, determine what your client needs and doesn't need, and then have a conversation with that healthcare provider. Why are you having your client do clamshells? Because unless they're early into rehab or getting prepared for surgery, or just having had surgery, so early in the rehab process, it's a very inefficient, inefficient exercise. And I did this for years with my clients, my patients in my office with knee pain, or clients that would stand and their hips would go off to the side. It never worked. It never worked. I'd have clients do this for weeks. Go home and do it. Do your homework. And these are clients that did their homework. They would come back, and every single time they'd stand on one leg and you see their hips go up like that. Or they'd walk and you see their hips give out like that. It doesn't work. The exercise doesn't work for that purpose. Now, if you say, hey, Dr. Osar, what about hip mobility? Does it help for hip mobility? Yes, it does. It helps to teach a client how to dissociate or move the hip, the femur, the ball inside the socket. So if you're using it for that purpose, then absolutely. But here's the challenge. Here's one of the challenges. Is if your client already has tightness of their external hip rotators, and if you're dealing with older clients with knee problems, they already have tightness of their external hip rotators. That's why so many of them, when they stand on one leg, they grip like this, and they walk like this. They walk in this sort of duck walk or waddle walk because they're already too tight back here. And they're also already too tight because they're tucked into posterior pelvic tilt. Why is that? If you've been watching us on Integrative Movement Insider, so subscribe if you're not subscribed, because we share all this great information with you. Most of your older clients, almost all of them, not all of them, but almost all of them, are tucked in posterior pelvic tilt with tight external hip rotators because they have spinal stenosis, and that's the position, that's the way that they create more space in their spinal canal, is by going to posterior pelvic tilt. Well, that will also lead to a shuffling sort of walk, that will lead to instability when they get onto single leg, balance, and walking issues. Now, one of the things I'm going to talk about today in about an hour and 15 minutes with my friends over at Functional Aging Institute is the idea that walking speed, not how long or how much your client walks, but their walking speed is directly correlated to longevity. So that means the faster your client walks, not necessarily how far they walk or how often they walk, but their walking speed, which probably also relates to walking more, walking faster, walking more frequently, is directly correlated to longer life. So what we can do, you and I, as health and fitness professionals, is help our clients improve those things that improve walking speed. Clamshells, not it. Another exercise, that's not it. It is this exercise right here. So, side lying, lift your leg up and back down. And if you actually put your hands on your client's side, you'll feel that they're using way more low back, their quadratus lumborum, and their obliques. They're rarely actually keeping their leg long, their pelvis stacked, and actually going out like that, which is crazy hard. Even that doesn't really correlate to the upright position very well. And again, you say, hey, Dr. Osar, I'm doing some isolated work so that I can integrate it later on. Okay, maybe. But again, doesn't really translate to the upright position. So, number 1, clamshells. Number 2, side lying leg raises. Third exercise, not super effective for a lot of your clients, especially with knee problems, knee osteoarthritis, is sitting on a bench or on a machine and doing knee extensions. Again, you can say, hey, Dr. Osar, where's your research on that? Well, if you look at your clients with knee problems, most of them have overcompressed knee joints. Guess what this exercise will create more of? Overcompressed knee joint, because it's tightening up the quads. It's tightening up the ligaments that are already tight. It's not tightening the ligaments, but it's creating tightness around the knee joint. It's actually not helping improve knee function. Now, is there a moment or a time and place to do some isolated quad strengthening? Absolutely. But is that what your client needs? And if so, what have you done to determine if that's what your client needs? So again, 3 exercises: clamshell, side-lying hip abduction, knee extensions. As standalone exercise, not so effective for your client that has knee osteoarthritis. So, Dr. Osar, what do you recommend instead of? I have lots of conversations here by myself, because I'm here by myself quite a bit in my little lab here. So what do we recommend instead? Obviously, we have a strategy to work with clients with knee problems. And in fact, this works super well. I worked with the client virtually. 1 session. She'd been to her physical therapist. The physical therapist had her doing a bunch of exercises. Most of them, actually I took her off all of them. Most of them were causing more knee pain, and they weren't helping her stand on one leg. You see, Sandy was someone who, she was struck by a drunk driver, like physically struck. She was walking down the street, was physically struck by a car, a drunk driver. She was dragged for several feet, or like a lot of feet, not several feet, a lot of feet. She almost lost her ankle and foot on her left side. Well, she found a surgeon she was actually here in Wisconsin. She found a surgeon who was able to save her ankle and foot. And however, she's had a lot of degenerative changes in that ankle and foot on the left side. So over the last few years, she's been compensating on the right side. So now she's got degeneration of her knee on the right side. So she'd gone to physical therapy right before COVID hit last year, and he'd given her this series of exercises. And again, all of them were causing her pain, and none of them were helping her. So here's what we did with her. And again, this is not the exact thing I did with her, but this is what I taught her. You know what? This is the exact thing I did with her. It's not even like maybe. This is what I did with her, because it was all virtually. So this is exactly what I did with her. So I'm going to share with you 3 things you can do with your client that has osteoarthritic knees. However, you have to have done your own assessment. You have to do your own history on your client to know what they need and or don't need, the indications and contraindications. So remember, the first thing I said was a lot of your clients with degenerative joint disease or knee osteoarthritis, they have a compressed knee joint. Now they can be compressed both this way, axially, so the whole knee is compressed. However, they're oftentimes compressed either that direction or that direction. So some of your clients will be in a varus knee position like that. Some of them will be in valgus knee position like that. Let's stay with a valgus knee just because it's just easier to understand. Phoebe, every time I talk, wants to get in on the action. Actually, she just wants to remind me that it's almost her lunchtime. It's past her lunchtime. In fact, all day long is her lunchtime. So you get your client, valgus knee position. They're over compressed on this lateral knee, the lateral side of their knee. Well, if you don't release the lateral side of their knee, you will not get great results with them, because they will strengthen, and she's just reminding me like, hey, yes, you know, it's good information, but speed it up so you can feed me. So they'll have lateral compression, and if you don't release the lateral compression, all your exercises will just reinforce the lateral compression issue. So here's what you want to do. Number 1, grab yourself a trusty roller. Rolga is our go-to roller. We love this for the knee especially, because you can put your client's leg, right in one of these zones. Here's zone 1, zone 2, zone 3. So we put the leg right in the zone. So let's use my left leg. I'll put my leg in the zone here, because what you want to do is release the structures on the outside of the knee that's causing the knee to drive in. That would be your lateral hamstring, your client's lateral hamstring. The IT band also comes down here to insert into the Gerdy's tubercle of your tibia. That will also create that lateral compression. So you want to do some myofascial release using the Rolga. This is a great tool. You can lean, roll yourself so you're on one side of the Rolga. So this works super well to release some of the myofascial compression. That's still not enough though. Then what you want to do is you also have to release some of the ligaments. That's not enough to release the ligaments. That'll release the myofascial tissue around the knee. You have to release some of the ligaments. So we're going to get around the kneecap with the fingers, get around the kneecap, and just do some very, very, very light and gentle mobility work. So just work around the kneecap So this is your kneecap. You're just kind of working, just doing a little light massage around the kneecap. Just very, very light, right around the kneecap. And then also there's a ligament here, the lateral collateral ligament. Collateral means there's two ligaments on each side of your knee, or one on each side of your knee. So it's a collateral ligament on each side of your knee. So you just want to do a little bit light myofascial release along the joint line, just to create a little bit of myofascial release of that lateral side. You can also do a little bit of myofascial release down here. Let me see what else I got here that will often work really well. I got my other little tool here. Where is it? Here. Hang on a second. Hang on a second. I give all day here. I can't find it. Where is it? Shoot. It was here. All right. Just say this is your myofascial tool. You can also, just a lacrosse ball, you can also do myofascial release on the lateral side of the, where the gastroc comes up and attaches here to right behind the knee, because it also crosses the knee joint. So you can do some myofascial release there. You can also do some myofascial release, because again, remember the fascia blends down into the muscles that are here in your extensor group as well. So do a little bit of myofascial release there. So that's the first step, do your myofascial release. The second step is you have to teach your client how to better align that knee joint. One of the best ways to better align the knee joint is, let me back up here, is to position them appropriately when they do something like a hinge. A hinge is a great pattern. So really, the second step is to teach them how to hinge so they can use their hips and also align the knee. So place the feet tripod, so the tripod of the foot down on the floor, align that thoracopelvic cylinder, get the inside of the foot and heel down, so that way you have that ground of the underneath the big toe and the inside of the heel. Get the fifth toe down as well. Create that foot tripod, hands on the pelvis, small knee bend. But the small knee bend just allows you to better hinge and then lengthen through the posterior hip. When you're looking at your client from the front, you should not see their knee like this. So you keep the inside of the foot down and then teach them how to bring that foot out without moving. Bring the knee, learn your anatomy, Dr. Osar. Bring that knee out without lifting the foot. Because too many people, when you put a band around their knee, they're just rolling themselves to the outside of their foot. They're not actually moving their body around the foot tripod. So put the foot tripod down, bring the knee out, then hold that position, then hinge. Because what we want to do is essentially lengthen the outside of that knee. So again, they should feel it here in their posterior hip, here in their hamstrings, and also maintain the foot tripod so their weight is over their feet, not back here like this. So when you see your client hinge, they shouldn't be hinging back, pushing their hips way far back like that. They should be over top their feet. That is a hinge, because what we want to do with a hinge is an anterior rotation of the pelvis. It's not this right here, because this doesn't allow me to go into anterior tilt. It's just pushing the hips back, and they're still in posterior tilt. That's why your clients feel like they're going to fall backwards. So hands in the pelvis, create rotation. So sometimes, oftentimes, most of the time, you have to do some release back here as well to allow that to happen. Myofascial release, hip hinge, number 2. The third is some kind of movement where you teach your client how to stabilize on that single leg. It can be a step out pattern like this, just teaching your clients to align, the same alignment you just had your client in. Instead of a hinge here, now you're just doing a step out. Because now, if you watch, now I'm teaching the glute, where I should feel it is in the glute. I should feel the pressure in the glute on my foot tripod as I step out. And there's no change now of the alignment of my foot as I step out. So that way I'm teaching the glute complex how to maintain that knee. Once the client gets good, then you can put the band around the knee. There's nothing special about the band. It's aligning the hip, knee, ankle, and foot complex and maintaining this alignment during movement. Then put resistance on it. So that way you teach your client how to better align the knee joint along with the hip, the pelvis, as well as the ankle and foot complex, and then help your client transition into the upright position, because you have to transition them to the upright position so that they can progress and move. And again, if that is still too uncomfortable, because some of your clients, they're coming to you and they're really at the end range or the end stage right before they're going for a knee replacement. Then just stay with things like bridges. Stay with things that are on the table. That's another reason why you may use some of those clamshells and sideline leg lifts. Still don't love them because they're not really teaching the client how to use their muscles appropriately. However, you have to do something to keep them active until they go into their surgery. However, use these concepts when your client comes out of surgery as quickly as possible, go through the progressions, and help them move towards successfully aligning and controlling their knee and their lower extremity. And that's how you become the go-to specialist for so many people that have knee issues so they can walk faster. Remember, faster walking speed relates to longevity. So, hope you enjoyed this. This is Dr. Evan Osar with Integrative Movement Insider. Subscribe if you like this. Share it with your like-minded colleagues and friends. We don't want any haters here. But if you want to hate on me, absolutely, go ahead. Put your comments in. I'd love to hear your comments. Put them in the chat box there, and I'll respond to them later today. I have to go get prepared. First, I gotta go feed the cats. Get prepared for our 1 o'clock Central, 2 o'clock Eastern Time webinar on knee osteoarthritis and solutions for knee osteoarthritis. Make it a great day. And if I don't talk to you before then, I'm going to talk to you before then though. In case I don't talk to you before then, have a great holiday season. This is one of the best times of the year just to sort of reflect on family, friends, getting together, the nature of, today's the first day of winter. Happy winter to those of you wherever you are. Hey, have a great holiday season. Thanks for all you do. Remember, there's darkness in the world. There's a lot of darkness in the world. There's more darkness likely coming to our world. Regardless, be the light. Be the light for yourself, but more importantly, be the light for those individuals that are lost, that need you to step up and be that leader for them, to give them that hope in this time of darkness. So thank you for all you do. If we can help you anytime during this season and going into 2022, please reach out, let us know. Dr. Evan Osar, we look forward to seeing you in the webinar. We look forward to seeing you next time on Integrative Movement Insider, and look forward to seeing you in 2022. 2022. Be safe, be healthy, be happy. Happy holidays. And goodbye from Phoebe as well. She's so happy that I'm done.